To chapter 47, pain. In the last video we ended with the gate control theory and Melzack and Wall and talked about the TENS unit. Okay, on this one we're going to look at endorphins. And this is broken down into enkephalins, and endorphin polypeptides, and there are three of them, and it is the alpha endorphins, the beta endorphins, and the gamma endorphins. The beta endorphins are the most studied. Okay, so in other words, when you release endorphins, this is pain modulation. So it does help block pain or decrease pain. And in some people, like runners, this is what is released to give you the so-called runner's high. Okay, these come from, with pain modulation. Okay, here's our pain fiber, the nociception. Okay, so something happened where you're hurt. Now the signal is coming in through the sensory nerve, a nociceptor, into the dorsal nerve root, into the dorsal horn. And because it's pain and temperature, the neurological signal is going to cross over at the level of the spinal cord, hit that anterior lateral system, specifically the spinothalamic tract, and then go up to the brain. Well, then what happens is, at some point during this synapse, substance P and enkephalins will be released on the dorsal horn here on the lamina, which is part of our central inhibition. Okay, this goes back to pain modulation. Okay, now this is the end product. So let's start at the beginning. Okay, so the beginning is going to be this periaqueductal gray. Okay, so the periaqueductal gray, or the PAG, and this is where endorphins are released. And the endorphins, which we just talked about here, so enkephalins, endorphins, alpha, beta, or gamma, these are our natural opioids, are released. And what they're also going to help do is include serotonin, okay, or this 5-hydroxytryptophan. The rostral pons is responsible for the release or the utilization of the norepinephrine that is going to communicate with the Raphe nucleus, which is found in the brainstem. And its job is also to take this 5-HTP and convert it into serotonin, which plays a crucial role in things like mood, sleep-wake cycles, appetite, in this case, the perception of pain. And then eventually these chemicals get put on that synapse area on that dorsal horn, which will help with pain modulation. On this slide, it is looking at the ascending pain pathways. Ascending meaning body to brain, so you can see these pathways going up to the brain from body to brain. And then on the blue side, these are the descending pain pathways. More specifically, the pain modulation for descending and pain modulation for ascending. So in other words, if a person is experiencing pain, the question is, what kind of medication should we give this person? Should we give this person ascending pain blockers or descending pain blockers? So here's some examples. Acetaminophen is an ascending pathway blocker. NSAIDs, ascending pain blockers. So NSAIDs are non-steroidal anti-inflammatory drugs like ibuprofen. Lidocaine, capsaicin, so these are all ascending. Menthol, opioids, cannabis, and ketamines. On descending, okay, the antipileptic drugs like gabapentinoids, sodium channel agents, antidepressants, TCAs, SNRIs, which is a serotonin norepinephrine reuptake inhibitor. And the TCAs are tricyclic antidepressant medications. And then cannabis and ketamines. So these are more influences on the central nervous system, but they are also supposed to help with descending pain pathways. So sometimes if a person's in pain and they were given a medication and the patient says it's not working, it may be the wrong pain pathway that they were given. Okay, these next several slides are just some diagrams to show you or remind you of the pain pathways to the brain. So this one is the dorsal columns, right? The fasciculus gracilis and fasciculus cuneatus, and these are responsible for tactile. So the information comes in the dorsal nerve root into the dorsal horn, and it travels up the dorsal column, and it's ipsilateral. Okay, notice the signal is on the same side. Once it gets into the brainstem, then it crosses over, which is decussate, and then eventually hits the thalamus, and then that particular area of the primary sensory cortex. And this is the homunculus. So it looks like this particular area is going to have to, whatever happened down here is going to synapse on the hand. Okay, so that particular area controls the hand. All right, so another view of the dorsal columns. Tactile information goes in, dorsal nerve root into dorsal horn, synapses on the dorsal column, goes up to the brainstem, crosses over, hits the thalamus, goes to the primary sensory cortex. On the pain side, or pain and temperature side, information will go in ipsilateral at the level of the cord and then cross over. So there's your contralateral. So pain and temperature crosses over at the level of the cord and then proceeds to go up and through the brainstem to the thalamus into that particular area of the primary sensory cortex. Okay, types of pain. There is physiologic pain. This is when tissue injury has occurred and it's designed to prevent further injury. And then it's stored in long-term memory. So an example would be touching a hot stove. So if you've never touched one before, or let's say get burned, well, now you know what it feels like, and that's stored in as memory. Pathological pain. The tissue injury has already occurred. Now it's chronic and debilitating, and the changes that occur will now have some long-term pain. Okay, an example of pathologic pain would be things like fibromyalgia, cancer, arthritis. Okay, so these create long-term pain. Acute pain is immediate onset of tissue injury. And so the pain begins on the onset and it can last up to 3 to 6 months. Signs and symptoms can be elevated heart rate, elevated blood pressure, elevated respiratory rate, pale, sweating, nausea, grimacing, crying, and moaning. Immediate treatments are typically pain medication, and then try to remove the provocative factor. So, for example, if it's a dislocated shoulder, then you would put the shoulder back into its socket, and then that alone will help reduce some of the pain, and then the appropriate treatments after that. Headaches. There are many different forms of headaches. There's tension headaches, migraine headaches. And with migraines, that can be craniovascular afferent fibers that cause it, an irritated brainstem, the release of calcitonin, gene-related peptide. Okay, now make sure you highlight that. Calcitonin, gene-related peptide, also known as CGRP. Okay, this one is a big deal because it's often overlooked, and it is the culprit in a lot of people, but no one ever talked about it. If a person has CGRP migraine issues, there's really nothing that touches it other than medication specific for CGRP. In my clinic, I treat a lot of headaches, a lot of migraines, and the methods that I use are very successful. However, if it's a CGRP person, then nothing's going to work except the medications that's going to help with that calcitonin binding. Once it binds, it causes vasodilation in the head, so that excessive blood vessel expansion is what contributes to these particular types of migraines. Also, other inflammatory cascades and stimulation of the trigeminal nucleus caudalis. Okay, so that would be right here. Okay, the trigeminal nucleus. And this is where you have the spinal accessory nerve and the trigeminal nerve and the greater occipital nerve that all come together at this particular, and the vagus nerve that all come together at this particular area. And what happens is when this gets overstimulated, right, in this particular area, it is, here's a better picture of it right here. It is very uncomfortable, very painful. A lot of this can happen from mechanical pressure, so that forward head posture, people who've had whiplash or other neck traumas, arthritis, degeneration, disc degenerative disease, and so on. There's a lot of things that can irritate that trigeminal nucleus caudalis. Okay, also an irritated trigeminal nucleus caudalis can cause or contribute to trigeminal neuralgia, also known as tic de la Rue. Okay, so with the CGRP, the calcitonin is released and binds to blood vessels and causes this vasodilation. And in conjunction with the trigeminal ganglion and the trigeminal nucleus caudalis, which is the relay center for this pain, being now overactivated or overstimulated. So here's an example of some things that can contribute, in this day and age with smartphones and screen time and all that. This posture is very common, contributing or possibly causing this condition. So if you are slightly forward with your forward head posture, okay, even slightly, it's 10 to 12 pounds that these suboccipital muscles have to hold that head up. At 15 degrees, about 27 pounds. At 30 degrees, 40 pounds. And then between 45 and 60 degrees, it's up to 60 pounds of pressure equivalent that the suboccipitals and the posterior neck muscles are experiencing. Also can cause a shift in the vertebral bones and the disc, causing a translation or a gliding that can start putting pressure on the nerve roots and tethering the spinal cord, which contributes to some neck pain and headaches. Also, if the atlas or any other cervical bone is malrotated or subluxed, it can cause a misalignment, which causes spasms in the musculature, because remember, if the brain thinks an area is hurt, it will always guard and protect. And the chronic spasms can eventually cause headaches and or migraines. This abnormal bombardment, once the skull and the shoulders and the hips are out of alignment, pulling on the spinal column, causes this overstretching and this overcontraction of muscles, which can contribute to back pain and hip pain and knee pain and foot pain. Okay, now the treatments for these are very simple. It's manual treatments to calm down the muscles, realign the bones. I'm a fan of dry needling to calm down the tight and spasmed and irritated muscles. Here's another diagram that causes some referred pain patterns. So these are trigger points. And the black dots that you see are the actual hurt area. And the red is where it sends the pain. So the patient will feel it in the red areas, but what's causing it is the trigger points in those particular muscles. Okay, so even pain down the arm can come from some sort of scaling issue or sternocleidomastoid, TMJ issues, whether you're grinding your teeth at night or over chewing, such as gum and pen caps and things like that. The black, which is in the temporalis muscle, is what is irritated, but the person feels the pain in the upper jaw and in that head area, which can cause headaches. So these diagrams are very valuable. This is actually the reason for these diagrams is this was studied. These trigger point patterns and referred pains was studied. And once they figured out what the cause was, the treatment is to treat the trigger point in the muscle. And you can either do that with lidocaine, dry needling, or Botox. Those seem to be very effective in calming down these trigger point patterns, reducing the person's pain, if not completely eliminating it. Other things that can cause headaches are sinus, like sinus infections, TMJ, so temporal mandibular joint issues, or your jaw, poor posture. Okay, poor posture, food allergy and sensitivities. So if you're putting pro-inflammatory things into your body, that can cause headaches. Caffeine, MSG, monosodium glutamate, and dehydration can contribute to headaches. Hormone issues, including maybe something's wrong with the pituitary itself or the optic chiasm. A brain tumor, infections, hydrocephalus, increased intracranial pressure, traumatic brain injury, and lack of sleep. So some of these are serious, such as the intracranial pressure and traumatic brain injury. Okay, other things like your posture and dehydration, those should be easy fixes to help resolve a person's headaches. Okay, treatments include medications, realignment of the bones. Like earlier, we saw the atlas was all rotated funny. Dry needling to calm down the spasm trigger points. PT, massage, diet and lifestyle modifications, and ergonomic improvements. So try not to slouch so much. And that so-called tech neck, where everyone's slouching at the computer. Chronic pain is 6 months or longer of the pain, and inflammatory mediators, increase of nociceptive recruitment. So nociceptive is your pain fibers. The person risks depression, fatigue, irritability, loss of motivation because of the chronic pain. And the central nervous system undergoes long-term plastic changes. Okay, keep in mind the brain is neuroplastic, so it can adapt to things even if it's negative things. So these long-term plastic changes are associated with chronic pain and depression, and treatments for this are oftentimes very difficult. Fibromyalgia is a widespread idiopathic pain disorder. Some theories on what it is excessive stress, plus abuse, plus viral infections. An example of those viral infections would be Epstein-Barr virus, the parvovirus, hepatitis C. And so the combination, for whatever reason, lingers in the body and stays there, creating these what's known as fibromyalgia. Okay, now that's just a theory, or what they think it might be from. Okay, and also throw in there some endocrine disorders and pro-inflammatory diets that can contribute to the fibromyalgia pain. These conditions are very difficult to manage. I have found success with an anti-inflammatory diet. So obviously, if you reduce inflammation, it can help with the fibromyalgia. And stress relief, some form of exercise can help. Cancer-related pain. A variety of factors go into this. The tumor itself and the expansion of the tumor, radiation therapy, chemotherapy, the chronic activation of the sympathetic nervous system, right? So that's your stress nervous system. Depression, anxiety, and fear can all contribute or enhance a person's pain. Neuropathic pain is chronic pain, often debilitating by lesions or diseases of the somatosensory nervous system. It can be attack on the peripheral nervous system or the central nervous system. The pain is actually from damage to the nerves. And the nerve damage can be from side effect of surgery tumor growth, metastasis, radiation, chemo, diabetes, viral infections, and trauma. Onset of pain can be weeks, months, or even years after. Neuropathic pain tends to produce cytokines, nerve growth factors, alterations in calcium and sodium channels. This is why sometimes people are put on calcium channel blockers. Hyperpolarization, activated nucleotide gated ion channels. And these HCN ion channels are integral membrane proteins that play a crucial role in regulating the membrane excitability of cardiac and neuronal cells. Also, potassium channels can contribute to neuropathic pain. These are difficult to manage, and this type of pain does not usually respond to pain medication. Trigeminal neuralgia, also known as tic de la Rue. This is where the trigeminal nerve is hurt. Usually the second and third division, also known as the maxillary and mandibular division, or V2 and V3. So that would affect the maxillary and mandibular areas. It causes severe facial pain, and it's thought to be some sort of compression on the nerve root over the ganglion, or the ganglion itself, or the trigeminal nerve itself is somehow being infringed upon. Creates a lightning, shocking, aching, burning, tingling, stabbing, crushing, and throbbing pain. It is brutal. It does seem to respond somewhat well to manual therapy and needling to calm down the spasming, but overall these are difficult to manage. Diabetic neuropathy, this is damage to the peripheral nerves and activation of inflammatory cytokines. What happens over time is the person starts to lose vibration and sensory touch. So this is a nerve thing. So the nerves are starting to die, and that vibration falls under those Pacinian corpuscles, Meissner corpuscles, your mechanoproprioception. So it's not necessarily taking a tuning fork that vibrates and placing it on a person. When we walk, there's a vibration. Because there's some pressure that the body and the nerves are experiencing in order to maintain your balance, maintain your proprioceptive. All that is neurofeedback under the term vibration. The patient may complain of numbness, and tingling and weakness. The patient also might have balance disturbances. Okay, what happens over time in diabetic peripheral neuropathy is, keep in mind, when you decrease circulation, when you decrease blood to tissue, tissue will slowly die over time. And that's essentially what happens. The microcirculations, such as the capillaries, start to die off. And because capillaries inevitably innervate the nerves start to die. And at that point, you're going to lose sensation. So there's loss of sensation, loss of circulation, and it can be as bad as getting ulcers, infections, and gangrene, which would inevitably end in an amputation. The presentation is called stocking and glove. So stocking and glove, and so socks and gloves would be another way of saying that, where there's this discoloration in that particular area of the body, the so-called stocking and glove pattern. Ischemic pain is loss or lack of blood flow to tissue. So ischemia is lack of oxygen to a specific area in the body. This decreased perfusion leads to tissue hypoxia and injury. Inflammation and pain-producing chemicals are released, and the patient may describe it as aching, burning, or prickling, which is your paresthesias. Atherosclerosis may be a cause. That's where the blood vessels getting all clogged up and decreasing blood flow to a particular area. Intermittent claudication is a type of ischemic pain. An example where this is commonly found is in the gastrocnemius or the calf muscle. And what actually causes this pain is exercise. So, for example, running. So the onset is through activity and usually goes away once the person stops the activity. Okay, so in other words, look at this as a pretty significant Charlie horse to the calf muscles, or this can happen anywhere in the body, but it seems to be pretty common in the gastrocnemius area. So treatment is rest. I've also found that nitric oxide can help. And the goal or the point of nitric oxide is to cause vasodilation. Okay, referred pain is pain that is perceived in a distal area than the actual site of injury. So, for example, if your heart is hurt, they may feel it in the chest, the jaw, or down the arm. If the kidney is hurt, they may feel it in the low back or in the groin area. So this diagram shows you the different areas of where the patient might point on their body complaining of pain in this area, but it may be coming from an internal organ.